Welcome to Asthma Canada's webinar on asthma and exercise, what you need to know. Physical activity, of course, is vital for overall health and well-being for everyone, but for those with asthma, it can be unique in terms of the challenges that the disease presents when it comes to exercise and physical activity. Many people wonder how to exercise safely while managing with their condition, and that's why we put together this session here today. We have two excellent speakers lined up, Dr. Alan Kaplan and also patient advocate Josh Rheaume, who will be sharing their expertise and their own journeys as well. So I'm Jeff Beach. I'm the president and CEO of Asthma Canada. Before we dive into our topic and hand things over to the presenters, I just want to cover a few quick notes, housekeeping items. This webinar is being recorded. It will be available shortly once we do a bit of editing with it on our website soon. So feel free to share it widely. That's the whole point here, is it's not just for those that are attending live, but we want to make sure that we get this information out to as many as possible. So please keep that in mind. Also, just to note, all attendees are muted, but if you have questions, we do welcome them, and we ask you to type those into the chat or the Zoom Q&A feature. We're going to try and cover as many questions as we can at the end, and we also know that there are always more questions that we can get to, so we'll do our best to try to get to as many as possible. Some people submitted questions in advance. Thank you for doing that if you did. And we'll try to make sure we cover those questions in the content and or the Q&A afterwards. Please note, we will not be able to address general asthma questions today. If you have questions outside of this specific topic, you're always welcome to reach out to us through our asthma and allergy helpline, and we'll provide some more information at the end of the session on that. And finally, we need to note, of course, that this is a webinar being presented for informational purposes, not any specific medical advice. We can move to the next slide. We do want to take a moment to acknowledge the Indigenous peoples of the lands that we are on today. While we're meeting on a virtual platform, we do take a moment to acknowledge the importance of the land, which we all call home. And we recognize that those who are with us today are joining from various lands and territories across this nation. So thank you very much for that. And just a quick note about asthma and Asthma Canada. Asthma is a very common yet serious disease. It affects more than 4.6 million people in Canada, and about 5 to 10%, we estimate as many as about 465,000 of those have severe asthma, which is particularly difficult to treat. It affects children and adults of all ages, and it is a disease that unfortunately claims the lives of around 250 to 300 people every year. So part of our mission is to raise not just awareness, but concern about the situation facing people with asthma and how they can empower themselves to live better with this disease. Next slide, please. So Asthma Canada is a registered charity. We celebrated our 50th anniversary of the founding of this organization last year, and our focus really is on our mission pillars, which are education, advocacy, and research. We invite you all to visit our website, asthma.ca, or again, connect with our asthma and allergy helpline, which will provide a direct connection for you for any questions that you may have to a certified respiratory educator in English or in French. And you can find more information about this and all of our information at asthma.ca. Now we'll go to the next slide, and I'll be introducing our speakers and calling on our first speaker, which is Josh Rheaume. So Josh is a passionate asthma advocate, a patient advocate, known online to many on Instagram and other platforms as the Asthma Runner. He lives with severe asthma and completed his first marathon last year in support of Asthma Canada and with Team Asthma at the Toronto Waterfront Marathon. He's here to share how staying active has been a powerful part of his journey and how it can be a part of yours as well. So Josh, I'll turn it over to you.
Thank you, Jeff, for that kind introduction, and thank you everyone for being here as well. My name is Josh Rheaume. I am an asthma patient advocate. I now consider myself a runner and host of the Beyond the Weeds podcast as well. And I've lived with severe asthma since birth. As a kid, I was hospitalized often, I'd say on average about 3 to 4 months per year, And for most of my life, I believed exercise, especially running, was something that I wasn't built for. Not only that, I believed it was something that I was told not to. I mean, thankfully, we've learned a lot more, and that's why we're here today. But a few years ago, after gaining a lot of weight and facing new health issues, I knew that I needed to make a change. So I decided to try running. Now, even though I had always been told to be cautious, and that caution, of course, was valid, because before anything else, really, it's critical to have proper control of your asthma. You need to be on the right medication, understand your triggers, and of course, speak with your doctor before starting anything new. For me, learning how to manage my asthma didn't really happen overnight. It took years to figure out what triggered it, cold air, dust, seasonal changes, what have you, and really how to adjust to my environment, and to be on the proper stack of medications. That foundation made it possible for me to eventually train and build endurance. When I first started running, I really couldn't make it 100 meters without needing my inhaler. I couldn't go for long hikes. I couldn't do anything like that. It was certainly scary, as I'm sure a lot of you can relate. But I stuck with it, and slowly that 100 meters became 500, became a kilometer, and eventually I was running marathons. Running didn't cure my asthma, but it changed my relationship with it. My lung function improved. I had fewer flare-ups. I felt stronger both physically and mentally, and it became a powerful part of my asthma management, not something to fear, but rather something to work with. If there's one thing that I've learned, it's that movement, when approached carefully and with the right support, can be a game changer, not just for fitness, but for confidence, breathing, and quality of life. It certainly changed my life. So thank you all for letting me share my story in a nutshell. And I hope that it shows you that with the right tools, support, and mindset, exercise really can be a powerful part of living and managing your asthma.
Absolutely. Thanks so much, Josh. That was a very fitting way for us to kick off today, and we really appreciate you not just joining us, but putting yourself out there, sharing that story. I know you've inspired countless people already, and you've launched a podcast recently, Beyond the Wheeze, which I was honored to be interviewed as part of. So thank you so much for all you're doing for the community and for Asthma Canada as well. So with that, I'm going to now introduce our next presenter, our very own member of our Medical and Scientific Advisory Committee for Asthma Canada, Dr. Alan Kaplan. Dr. Kaplan is a family physician practicing in York Region in Ontario. He's the chairperson of the Family Physician Airways Group of Canada and the vice president of the Respiratory Effectiveness Group. As I mentioned, he also sits on our Medical and Scientific Advisory Committee, and has been a very active contributor to the work of Asthma Canada for many years. As you can see from the background, he is in clinic today. So Dr. Kaplan, we really appreciate you taking time, as you have many times before, to join us, and I'll turn the floor over to you now.
Thank you, Jeff, and of course, Jenna from the Asthma Society. And Josh, thank you. That was really quite inspiring. And it just shows that it can be done. So many of you are sitting there saying, I'm not sure I can do this, but Josh has shown you from someone who couldn't go 100 yards, now he's able to run marathons. It can be done, and reinforces nicely what we're going to be talking about. Here's my disclosure. I work with virtually every company that makes anything inhaled and some others as well. So I think this is not going to be a situation that's talking about individual medications particularly. What I talk about here is the benefits of exercise for overall respiratory health, specifically for asthma management, and looking at how we identify and manage exercise-induced symptoms and how we deal with those. We want to give you some tips for how you can build up confidence in your physical activity, and things like warm up and which medications to use before and after exercise can be very important, how to deal with environmental conditions. So I'm going to try to touch on all of those things in our time together. I don't think I have to show you this picture. You all understand the concept of the normal lung. On your left and on the right side is the asthmatic lung, where you have swelling in the airways, which is the underlying problem. Then you get mucus production, you get spasm, it's there. But the underlying problem, of course, is that swelling in asthma. We're going to talk about something called exercise-induced bronchospasm, which is a little bit different than this is. But for most people who have symptoms with asthma, the problem is the asthma is not as well controlled as it could be, and exercise is a trigger. And I'll come back to all that. I'm going to talk about GINA. So GINA is the Global Initiative for Asthma Management. I was honored to be invited to scientific committee in the last few years. I'm going to come back to this global document about asthma and come up with some of the recommendations. So you can see here, this is out of an entire list of non-pharmacologic interventions, all of which are important, including obviously dealing with environmental triggers, smoking cessation, as you can see on the top, and occupational domestic exposures on the bottom. Things like cleaning fluids and stuff like that are there. But I want to get into the physical activity box here. So the recommendations here from this global initiative is encourage people with asthma to engage in regular physical activity. It's good for you in every way, shape, and form. So exercise is not a dirty word. It's an important word, and we should be doing that. Find something you enjoy and do it. We're going to talk about advice about prevention of exercise-induced bronchoconstriction. And I'll talk about the individual drugs shortly, so we can skip on that part for now. We're going to talk about how we talk about warm-up advice and using medication for exercise. We're going to talk about the fact that regular physical activity improves cardiopulmonary fitness. The heart and the lungs are related. They're all in the same cavity in your chest. They are related, and the better one works, the better the other works. And we'll talk about the different choices. And even in people, as Josh pointed out, with moderate or severe asthma, exercise is going to be helpful for you overall for your health, but also for your asthma. And we'll talk about different options for medications and how to choose for exercise choices, and for those people that are, that are not professional athletes and just want to recreational exercise. We'll talk about options. So this was a study looking at the effect of aerobic exercise on asthma in adults. It was a systemic review and a meta-analysis that was published in 2020. So what you're seeing here is this is a number of different studies that all get grouped up together to the total at the bottom. But what you're seeing there is that overall aerobic exercise, which is basically running, swimming, where you're not lifting weights, but just that kind of exercise, has benefit in asthma control. It has benefits in lung function, but interestingly, it doesn't have effects on the airway inflammation. So we still need to have enough asthma medications to control the problem. Exercise is something we do on top of that, and it's going to improve your lungs, as Josh said, and improve your lung function, and improve its control. But this does not mean it's to the exclusion of your medication. So a very important message there. First, we have to get good asthma control. Some work done by some colleagues of mine, Adriana Cote in Quebec, looked at all these benefits of exercise. And again, not surprising there. Improves exercise capacity, increases quality of life, decreases your symptoms. Air responses is how irritable your lungs are to an agent, and decreases exacerbation. So very similar kind of messages as we've already seen. Now, Cochrane is a group of people that actually review all the literature and come up with specific answers to questions. So this Cochrane review actually looked at swimming, because there's a lot of question about swimming. Is it good? Is it bad? Well, it's good. It's well tolerated. It increases lung function and fitness. And swimming is not going to cause adverse effects on asthma control. And so that's okay. Swimming is good. Now, we don't know whether swimming is better than other exercise, but it's certainly a very good exercise. There is a but here, though. In our GINA recommendation, we recommend that you got to be careful about the chemicals in the swimming pool. So when you're in an enclosed indoor swimming pool, there's certain chemicals like chlorine and trichloramine, which of course can itself cause bronchospasm. So you'll know that a lot of swimmers may have issues with their asthma not because of the swimming, which is good for them, because of the chemicals in the pool. An outdoor pool, this is not going to be a problem, but indoor pools, we all know you want an indoor pool, you can always smell the chlorine and so on in there. That's something that's going to be inhaled. Now, we live in Canada. So in Canada, some of you may recognize Connor McDavid's winning goal from the Four Nations. So we know that inside arenas, there's all kinds of levels of CO2 and nitric oxide and other ultrafine particles that are present because of things like the Zamboni machines driving around and cleaning the ice. Can't play on the ice without the Zamboni cleaning it off, otherwise you're going to have a very slow game. But all those chemicals do end up getting trapped inside the arena, which are often kept warm, so they're heated as well. You've got that also going on. So this, so certainly hockey itself is not bad for asthma, but exercise is not bad for asthma. But the chemicals are there; they can trigger things up a little bit and cause some symptoms. I thought this was interesting. So this is in a population of people who were not considered obese, not considered to be heavy, but they found that actually diet also makes a difference. So the exercise was good, but if you actually had a proper diet, cutting out that low sugar, making your diet a low sugar situation, cutting back on sugar, it actually improved asthma control and clinical outcomes better than the exercise alone. So we can do lots of things to help us, but the message of this slide is that a proper diet can also improve you. You don't think about that when you're talking about asthma, but there's certainly some benefits here along with the exercise to have a proper diet. In addition, while I said don't allow your medications to fall off and stop using them, this study in Denmark looked at 150 people who were on ICS, and they were assigned 2 to 1 to 6 months with supervised exercise 3 times a week, or do whatever they were doing before. And what they looked at is with that supervised 3 times a week regular exercise, it actually allowed them to cut their dose of medication down. And in fact, they could cut it down by about a quarter after about 6 months. Please don't do this on your own. Do this in conjunction with discussing it with your physician, please. But the point here is a regular exercise program is going to do all the things that Josh described, but also potentially could allow you a reduction in your total medication. And it reduced it by an average of about 234 micrograms, which is basically 1 puff of an inhaled steroid regularly. So something else, if you need that incentive to get out and exercise, it may allow you to take less medication overall. So let's get back to exercise-induced asthma. So what's the epidemiology of this? So it's about 12 to 15% of the population. And not all of the symptoms are people who are considered asthmatic. Most of the people are people who have got an atopic allergic condition like allergic rhinitis, of course, more common in asthma, but there's a population of people that are considered normal. And come back to those people who actually don't have asthma but have exercise-induced symptoms. It's more common in some winter or cold weather sports. I'm going to talk about why that is. And in certain populations and competitive skaters, ice hockey players, cross-country skiers, perhaps because of those temperature issues, it's a little bit more common, as high as 1 in 3. It's also common amongst swimmers, but it's also just overall common in elite athletes. So remember that. I'm going to come back to that. But clearly, cold weather is a factor. And I hate to break it to you all, but you live in Canada, so it's going to be cold weather. There we go. Now, are the symptoms of exercise-induced asthma different than normal asthma symptoms? And no, it's not. Asthma symptoms are the same: the chest tightness, shortness of breath, and so on, underperformance of performance. Fatigue is interesting. So there's a lady her first name is Rose. I'm forgetting her last name right this second. I met her in Portugal. She is one of the few Portugal gold medal winners, and she won it in endurance running. And when she was training initially, she didn't get short of breath or wheezed. She got tired. And it took a little while for someone to diagnose this fatigue as being asthma. And with a little bit of asthma medication, she was winning gold medals. So you can see how the symptoms can be non-specific, even GI symptoms. So it's not about different symptoms. It's about a trigger of those symptoms being related to exercise here. So obviously, if you can't exercise, and Josh described this earlier, that if you're not able to exercise, not able to keep up with your friends and so on, that's going to be socially awkward for children at school. It's going to decrease motivation to do things. It's going to impact our social development, our ability to play team sports, potentially even self-confidence, and then even academic progress. In addition, that fear of physical activities might end up being a barrier for other things in their lives for both the children and parents, for those of you that are parents of children with asthma. So we really want to make sure that we don't say, no, you got asthma, you can't exercise because you have asthma. It's the opposite. It's please do exercise because it's going to help your asthma. And I've seen way too many people over the years that were told, well, don't exercise because you have asthma. And then unfortunately, we get people who end up putting on some weight. They become couch potatoes because they haven't tried to exercise, because either they've had some symptoms, as Josh had described earlier, or because they're afraid of the exercise. So we have to turn that around, because the lack of exercise is going to lead to reduced fitness, poor asthma control, weight gain, and obesity. And obesity is an issue all by itself. Obesity does worsen asthma. So being heavy worsens asthma. And by a whole bunch of mechanisms that include a different inflammatory milieu, some hypersensitivity, even potentially some fat in the airways. So we really need to try to make a difference to that. And if we don't exercise and put on weight, it's actually going to worsen our asthma, and it makes it harder to treat because the regular treatments we use don't work as well. In addition, if we put on weight, then things happen like reflux. If you're heavy, then you get acid coming up, and that can worsen your asthma. And of course, it can also develop sleep apnea as you get heavy. That's a risk for sleep apnea, which of course is another part that's going to cycle the respiratory system. So again, exercise is good for you. So I want to break down some definitions to exercise-induced asthma, which I talked about. You have asthma, and the exercise is a trigger for the asthma. That's 90%. And overall, here's the message. The management here is get your asthma in perfect control. If there's no inflammation in your lungs, you won't be triggered by exercise. There's also something called exercise-induced bronchospasm. And these are people that don't have chronic asthma, but the exercise in itself, and sometimes it's cold air can do this as well, can actually induce bronchospasm by itself. And I'll talk about the mechanisms. And for these people, Treating them with inhaled anti-inflammatories regularly is not the management, and we'll talk about how to deal with that. So it's about 10% of people have exercise-induced bronchospasm. It's not common. Exercise-induced asthma is the common. I've given you the message there. We'll talk about exercise-induced bronchospasm as well. Now, how can I tell this clinically? Well, if you have bronchospasm, and here you can see on the y-axis on the left side is peak flow, which is a measurement of lung function, and time on the bottom axis. So if you're wheezing and getting symptomatic and your lung function drops during the exercise, that's likely exercise-induced asthma. So you can see where that peak flow is dropping in an asthmatic. If you compare this to someone who have exercise-induced bronchospasm, they exercise and they're fine. In fact, their FEV1 is not an issue, but then it falls after the exercise. So that's really when that's going to happen. It's going to happen after the exercise. So it's a clinical difference, and asking you to think about when you get your wheeze or when you get short of breath when you're exercising. If it's during the exercise, this is probably asthma that's not as well controlled as it could be. If it's after exercise, then it may be related to exercise-induced bronchospasm. The other hint I find clinically is that people who get colds but don't have wheezing or symptoms from their colds, again, but do have symptoms only with exercise, that's again a pretty good predictor of being EIB or exercise-induced bronchospasm. So they're different, and the pathophysiology is different. There's a couple of theories about this exercise-induced bronchospasm. One is that it's thermal-related temperature change. It's not a biochemical mediator. It's not the same eosinophils that we talk about otherwise with asthma. The other is it's osmotic, that the airways dry out. And the bottom line is it's probably a combination of both. I'll show you a picture of that. But overall, what happens here, the water loss causes an increase in airway fluid osmolarity, which then causes airway obstruction to occur and the muscle to contract. And then after that, you get mediators being released. So it's a combination thereof. Now, here's sort of a picture that I found from an article that sort of highlights this. That's probably a little bit of both. So if you start from the top left, the water loss leads to that hyperosmolar environment. The cells shrink, and then that causes contraction of the muscles, and then mediator release and vascular leak. That's important because that vascular leak leads to the release of mediators. And those mediators that are familiar to you, histamine, leukotrienes, prostaglandins, and secondarily eosinophils. Heat loss on the other side, going up, leads to airway rewarming, and then the vascular bed gets congested, and that congestion itself causes airway obstruction. So that may be a little technical. Forgive me for doing that if I bored any of you and lost you. But you can see here that there's been a lot of mechanisms discussed on this, and this is exercise-induced bronchospasm we're talking about. So you can see if water loss is the problem and you're exercising in a very dry area, then you need to make sure to hydrate as best as possible. If it's a very, very cold area, then warming is going to be important. I'm going to come back to that. These mediators, again, not terribly important, but cysteine leukotrienes are the medications we use for leukotriene receptor antagonists. And you're familiar with montelukast or singular as one of the options for treating exercise-induced asthma or preventing it. FeNO, fractionated cell nitric oxide, is a test that we use more and more in practice to look at inflammation in the lungs. Angiopoietin-2 is one of those vascular mediators that we don't measure at all, and mast cells we can't really measure in practice, but we know that they're part of the eosinophil cascade. A lot of words on this slide, so let me break it down to two things. There's a refractory phase, which starts less than an hour after the initial exercise and lasts up to 3. What that means is that in that refractory phase, you're not going to get symptoms refractory to the bronchospasm. So if you use the warm-up period and then get yourself well warmed up, then you have then a refractory phase after the warm-up, and therefore you're going to be free of symptoms after that. Then there's a late phase response, which happens anywhere from 3 to 9 hours. And while it's less severe, the initial response, then you get all the symptoms of the asthma. So that's why the warm-up is so important. We always talk about warm-ups. Nobody ever does it. Josh, maybe you do. You can describe what you do after. But the reality is that it's important for more reasons than you think. It's not just warming up the air, which is important as well. It's not just maybe hydrating, but also induces this refractory phase, which prevents these symptoms overall. Now, if you get symptoms of wheeze with exercise, there's a whole bunch of things it can be. It's not always asthma, either EIA or EIB. There's something called exercise-induced urticaria or anaphylaxis. It happens especially with certain foods. You combine certain foods and exercise, it can make the reaction worse. There's something called inducible laryngeal dysfunction, which is not asthma at all. It's a paradoxical close of the upper airways. of the vocal cords that leads to symptoms, and sometimes can cause some stridor. So you hear sounds on the way in. That's a hint for that. Something there, and it can be exercise induced as well. There can be other lung diseases. It can be heart diseases. You can be short of breath because of anemia. Anxiety can be a factor here. Poor conditioning. People say, "Well, I'm short of breath on exertion." And I say, "When's the last time you exerted yourself?" Well, maybe we're out of shape. And there's other swimming-induced things there as well that are less common. So how do we make this diagnosis? So we make this diagnosis usually just by the history. You don't need a bunch of fancy tests. We talked about when the timing of the exercise. You are going to get lung function done to see if there is asthma overall. Is there obstruction there? And overall, what's the situation? Peak flow meters are a very good way to do this. You can do this yourself. Use a peak flow meter and document that there's been a 10 to 15% fall either during or after the exercise. That's a simple test, doesn't cost very much. Hopefully, many of you have a peak flow meter already to help you manage your asthma. On the other hand, if you're a competitive athlete, there's rules and medications and competitions, so we have to have more definitive testing for them. But if any of you are competitive athletes, somewhat to talk about at the end will be relevant. If you're just social recreational athletes, then really you can just use a peak flow meter if you want to make that diagnosis. We talked about whether the onset's during or after exercise. How long do the symptoms last? If they're lasting longer than 5 minutes, it's probably EIA rather than EID. And again, we talked about EID will not occur during the first 5 minutes of exercise, it usually occurs after the exercise. So we're getting some ideas there. Now, you have to have symptoms and a positive test based on the International Olympic Committee and the World Anti-Doping Agency to do that. And again, you may have to go on to full bronchoprovocational tests to confirm asthma in patients who are actually competitive athletes at this level, because people try to use things like beta agonists to get a performance advantage. In fact, it doesn't work. But again, people may try to use medications that aren't necessary for them to get those advantages. Now, there's an older test called the free running asthma screening test. So this is a test that was first evaluated in Sheffield, England, with 500 kids who basically got peak flow meters before and after exercise at the times it says there. And again, looking at that fall in peak flow with 2 post-exercise readings was defined as abnormal. What was interesting about the FRAS test is that they found on average 1 child in every class that unrecognized exercise-induced bronchospasm. So really important, because that child may then go on to say, well, I don't do very well with exercise, I'm not going to do it anymore. Whereas we've made a diagnosis, we can actually change that child's life. This is validated in Canadian children. I just show you this study because, again, it's done in 1,000 children in BC and Ontario. And they, again, found that the previous diagnosis was 17% in BC and 24% in Ontario. And the FRAS was an additional group of patients, 13% in BC and 25% in Ontario. So overall, what you're seeing here is some of these kids had asthma, and of course, had a positive FRAS. Some of these kids were not diagnosed with asthma and now have a diagnosis of likely asthma in evaluation. I point this out, this is a number of years ago, it's 2004, but one of my colleagues and the executive in the FPHC, Anthony Chavarella from BC, was one of the authors on this. Then you can move all the way to a formal exercise challenge test, where again, you get people on a treadmill, they're all hooked up for sound and everything, and they're measuring their lung function as well as they're doing this, and which get people up to 85 to 90% of their maximal heart rate, and a drop in their peak flow or the FEV1 with this formal challenge test. I know that a question, Jeff, came in. I'll take the privilege of answering it now about how old you have to be for this. And so basically you can be as young as someone who can actually do all these testing and wear the mask and actually exercise. But if you're under 21, you'll have to have a parental consent to get this done. So it's just limited by your ability to do the test rather than by age as a number. Right? So if you have a little bit of a drop, 10 to 20% is considered mild, 20 to 40 is considered moderate. And if you're dropping FEV1 more than 40%, you're going to really feel that. That's considered a very severe positive exercise challenge test. The other thing we do, some of you may be familiar with the concept of a bronchoprovocation challenge. So here, because asthma is a variable condition, it can often be normal in between exacerbations, in between exposures and triggers and things like that. So the spirometry might be normal, but we do know that if we give an irritant, so methacholine and histamines are irritants that cause bronchospasm, cold air and exercise are often related in the way it works based on what I showed you already. So these tests can be done to then show that the FEV1 has then dropped with the provocation, and then it responds back to the beta agonist afterwards. You don't do this during a training period itself. You do this, during the training period if possible, because in people with exercise-induced bronchospasm, this test will maybe be negative outside the exercise period. So for exercise-induced asthma, it'll be positive as long as there's inflammation. For exercise-induced bronchospasm, again, you have to catch the time where they're hyperactive in their airways during that exercise. The other test now that's being talked about more, which is just sort of a little easier to do, is called eukapnic voluntary hyperventilation. So basically what happens here, it's usually in a laboratory, and what you're doing is you're just basically breathing really, really fast as you pretty well can in time, trying to breathe as much as like one every second if you can, with a dry gas inhalant. This dries out the airways and mimics that osmotic priming stimulus I talked to you about. This was established since 1984 to test Army recruits, and now has been used as pretty well the gold standard. So you don't necessarily have to do those fancy challenge tests onto the treadmill. This test is very effective, and it actually mimics the effect of exercise in drying out the airways. So basically, just breathing very, very fast. Any clinicians on the line, you can try to do this in your office, but it works better if you're sort of drying in a gas inhalant that's already dried out. Okay, so how do we deal with exercise-induced asthma, EIB? The first thing is make the diagnosis, which we've talked about it, and then please exercise. All right, it's important to exercise, be it a competitive athlete or a social athlete. Exercise is there. You can do it. It's going to make you better. Now, some people will get symptoms when they're exercising that's going to be significant. What do you do if the exercise while you're exercising you're getting significant symptoms? Well, you can take beta agonists. You can take as much as 4 puffs of your blue puffer, whichever it is. Come back to other puffers we can use shortly. And then if you get better, then you can probably go back to exercise because hopefully you're now in a refractory period of the beta agonist. But if they return, you better stop for that day. Right? So if you get symptoms, use your beta agonist, use enough to get better, wait a little while. If you're fine, then you can go on. If you are not fine, then you can't go on. And if the beta agonist doesn't work, then you need to get an ambulance and get help. Right? So that's how to picture for any of you who are exercising. I'm sure this has happened to you. You've had symptoms. What do? Well, you use your bronchodilator, and then if you get better, carry on. If you don't get better, you shouldn't carry on. And if you're not getting better at all with the beta agonist, then get help. Now, GINA, the Global Initiative for Asthma, also talks about the fact that it's okay to use budesonide formoterol. So ICS formoterol containing drugs are drugs that have formoterol, which is both a long-acting and a short-acting bronchodilator. What I mean by that is it works acutely but lasts up to 12 hours. So budesonide formoterol is now being used as a rescue drug. It's now being used as an as-required medication for people with mild asthma. The name of the drug in Canada is Symbicort. There's other budesonide formoterol combinations in Europe and so on. The one we have here is called Symbicort. So that's the one that's officially got the indication. It's going to be used to both treat the attack and help to prevent the attack. And the concept here is because we're giving some inhaled steroid budesonide at the same time as we're giving the formoterol, the opener, you're getting the inhaled steroid when you need it. And that's why it works as a rescue drug, because you're getting more inhaled steroid when the inflammation is occurring. So we're treating the inflammation as it's occurring. One of the questions has been, what if you give budesonide formoterol someone with exercise-induced bronchospasm, where inflammation is not the primary problem? It's still going to be a value, and I'll show you a study that shows you that. So I've talked already about exercise-induced asthma. The first step, of course, is prevention. Exercise will not trigger your asthma if you're in excellent control. And you all know what a control means, which means you don't have to grab your puffer, your lung function's normal, you've dealt with your triggers, you're not having exacerbations, you're never waking up at night. This is from our recent CTS guideline recommendations for that. So what else can we do? Well, you might want to think about what sport you're doing. If unless obviously if it's a passion, then don't change. But if you're just looking for something to do, and when you do it can make a difference. So obviously, when the air is warmer and humidity is higher, it's going to be better when it's dry and cold. Of course, in Canada, we're cold a lot, so you don't have that choice. But perhaps you can choose to exercise inside rather than outside, for instance. Maybe you change your sports. From running to swimming may make a difference in terms of outside. You can swim inside and so on. Obviously, swimming is nice because it's a good humid environment. And as a rule, aerobic exercise is worse than anaerobic. So it's better to do less aerobic demands like sprinting and weightlifting, stuff where you're doing spurts rather than long duration exercise. This gives you an example of that, right? So people that are doing marathons and so on, like Josh described, that's going to be sort of worse for exercise-induced bronchospasm and asthma, where short sprints are going to be better. But basically, any of them can cause these issues. But again, you may want to choose an exercise. So if you're into track and field at school, maybe you do sprints and middle distance and hurdles rather than go for the long distance running team. Now, in addition, we talked about humidity being an issue. So if you can learn to breathe through your nose, one of the things that breathing through your nose does is it warms and humidifies the air coming in. And if you just breathe through your mouth, nothing's filtering it on the way in. So if you can learn to breathe through your nose as you're exercising, that can actually improve and decrease bronchospasm. And there are actually some masks you can actually wear to keep the humidity inside the mask and warm things up. I can't see most people actually wearing these things, but again, they are available if you're so interested. So we talked about also the timing of the exercise. And I've mentioned this already, that if you can time the warm-up so the competition is during that refractory phase, then you're not going to get bronchospasm. So if you time it, do a good warm-up, and then you do your competition, you're in the refractory phase, you're not going to have drop in your FEV1, you're not going to have symptoms, and you're going to be able to compete successfully. So best to do a 15 to 30-minute warm-up, then a 15-minute a little rest down, just to cool down a little bit, not too much down. This it's good for your muscles to be warmed up as well. And that's the time where you're going to think about any preventative medication, which I'll come back to. So again, if you're going to take a medication, you want to start the competition, I'll say 15 or better yet 20 to 30 minutes, because that's the time that beta agonists have their maximal effect. All right, so I talked about the refractory period, but again, we're probably through the release of catecholamines and prostaglandins. Bottom line is, it's a real thing, and it's metabolic, and it can prevent you from having symptoms. So overall, you want to warm up, you want to cool down, you want to be well hydrated. We talked about where and when to exercise. Think about pollen counts. Now, this is real trouble. If someone is running track and it's outside in the summer and it's a high pollen day, you're going to get a lot more exposure as you're running outside. Hard to deal with that, hard to wear a mask when you're competing and so on. But you want to think about that, and perhaps maybe you'll increase even your controller medication for the week prior to the competition if you know pollen levels are going to be high, and you can look these things up in terms of pollen counts. Air pollution will be another factor, again, outside of our control. Air pollution. There's something called Air Quality Health Initiative, and if you look up the website airqualityontario.com, Air Quality Health Initiative, AQHI, and this will give you, anywhere across Ontario anyhow, it will give you the level of the air pollution from 1 all the way up to 10. And if you've got a bad air quality day, you can expect that you're going to have more troubles that day. A good air quality day won't be an issue. If you're training, a bad air quality day, perhaps you don't train outside, you train inside. Things like that can make a difference. And obviously temperature. So Air Quality Health Initiative, you just search that, you'll find it, Government Ontario website. Okay, so temperature, we've talked about this already. Try not to exercise routinely when it's less than 20 degrees. Remember the wind factor, because that's going to dry the air out even more. Trying to avoid sudden changes. So do your warm-up in the cooler weather rather than doing all the warm-up inside and then going outside and expecting to compete. Cool down outside at the same temperature as you are. Again, because otherwise that warming suddenly is going to cause a rewarming and causing some symptoms as well. And again, if you can wear a mask or a scarf or something to help rewarm, humidify the inspired air, that's going to be helpful. Now, the medications, everyone else wants to know what medications we can use. The mnemonic for this is Climb. So cromolyn is an old drug that we don't really use anymore, but it was actually effective, not so much for asthma, but it actually was effective for pre-exercise prevention. It was not a bronchodilator. Leukotriene receptor antagonists are pills. The most common we have in Canada is called Singulair or Montelukast. So you'd have to take that sort of the morning of to have enough sufficient level, maybe even the day before. Inhaled steroids are useful to some degree, not my primary choice for exercise-induced asthma. There are mast cell stabilizers other than cromolyn. We used to have one called nadocromil, which is actually probably better to it, but because of the propellant in it, it's taken off the market. And what most of you are familiar with is just using your beta-2 agonist, using your Ventolin, as we talked about. This is an old one. We've talked also about the fact that, sorry, that's not my next slide was. So that we want to do this just before. We talked about 30 minutes, 15, 30 minutes before the exercise. And so therefore we've got the bronchodilator in there to treat the bronchospastic event. We talked about maybe you can use a long-acting beta-2 agonist as well. So as a rule, we don't recommend long-acting beta-2 agonists by themselves because use of them without inhaled steroids can cause problem. But here, if you're going to be exercising all day long, like you're going to be out skiing all day, short-acting will wear off after 4 to 6 hours. Long-acting may last 8 to 12 hours. It may be a better choice to use for that. And there's another studies using inhaled steroids at a higher dose, and that's something else that can be tried, something to talk to your physician about. Beta agonists are what's going to be used most commonly. LTRAs I tend to use also for people who are going to be exercising on and off all day, and if it's effective for them, it's a trial treatment for them. Now, as I mentioned, Gina also mentioned you can use budesonide formoterol, and you can use that on demand for symptoms, but you can also use it preventatively before the exercise. And it's the study by Lazarina showed that if you compared terbutaline, which is the same Turbuhaler that we get Symbicort in, or Bricanil to Symbicort, it actually had a better overall response for it. So should we actually be using SABAs as the only treatment for exercise-induced bronchospasm? I'm not really sure about that, actually, based on this study. It's the only one done, though. And because the concept is if you get that warming and rewarming, the cooling and rewarming, and the drying out, it's releasing some mediators as well. So it may actually be that using an inhaled steroid formoterol combination may actually be better than using SABA alone. I think it's probably especially better for those people that have poorly controlled asthma. But again, mixing drugs becomes a bit of an issue there for us to talk about. So this sort of looks at the difference here. You can see that this is sorry. So before and after 6. So the top one is before, and what you can see is the budesonide is the hatched lighter colored, terbutaline is the dotted black, and the budesonide formoterol is the combination. You can see that either inhaled steroid tended to have a better response in terms of the drop in the FEV1. But if you compare it here, again, same sort of thing, and this is after stopping the exercise, you're seeing the same sort of picture. So this is reinforcing this concept that maybe it's time for us to move away from SABA as the pre-exercise treatment to something that's going to treat the inflammation as well, be that a leukotriene receptor antagonist, which in some people will do that, or an ICS formoterol, which could do that better. So if I take this summary from Adriana's work, overall for prevention, non-pharmacologically, reduce triggers as best you can, exercise regularly, do the warm-up, careful with the environment, as we talked about, mechanical barriers if possible. Don't exercise during respiratory infection if you can help it, because you know that that's just it's a situation where you're going to flare, and you should be stepping up your therapy for that. Medications can certainly be added on. This is prior to Gina's recommendation for ICS formoterol, so it's not included. This is an article 2018. We started talking about ICS formoterol in really 2019. So again, here we talk about good inhaler technique with whatever you're going to use, overall promote adherence to your regular controller, and of course, treat your coexisting conditions that could worsen your asthma and prevent control. Now, elite athletes are a little bit different in that actually they have a higher risk of exercise-induced bronchospasm. And as I said, they need a firm diagnosis, they'll take medications. And I've already told you, though, people have been trying this for years, the short-acting beta agonist does not make you compete better. It's not going to make your lungs work better. You don't have an indication for them, they're not going to work. Now, the World Anti-Doping Code says, can you have asthma and still be an elite athlete? And the answer is yes. And not only can you, I hope some of you recognize this. If you don't recognize him, you can see the number of swimming medals he has. This is Mark Spitz. He was an asthmatic, and he rewrote all the record books, as you all know, for winning gold medals at the Olympics. In fact, if you actually look at world-class athletes, there's something about the way that they train so hard that actually can induce airway injury. So overtraining, they need to overtrain at this level. I'm never going to hit that. And that's Josh, maybe you will as you become a marathon runner, but it actually can induce airway injury and worsen it. And what you're seeing on the right here is if you look at the different Olympics over time, you look at the percentage of athletes with asthma is the blue. You look at the percentage of individual medals that won by those asthmatic athletes. You can see the asthmatic athletes are way overperforming. So not only is it not an excuse not to exercise, you can see that asthmatic athletes actually overall do better than non-asthmatic athletes. And it may have something to do with the fact that they train so hard, they induce some airway injury. Again, there's rules about the use of the various medications, which I'll touch on, so you have to have a firm diagnosis. It's called a therapeutic exemption. You're allowed to use certain medications if it's necessary to treat an acute or chronic medical condition, and they'd have a problem if they were to stop it. It's not going to give any additional enhancement of performance. There's no alternative. And necessity to use the prohibited drug is not a consequence of prior use of a prohibited drug. So again, you can use pretty well whatever you need here, but again, you just need to check the rules. So overall, what's allowed, and again, this is 2016. I couldn't find a more recent one. I apologize for that. I'm sure this has changed a little bit. But the mast cell stabilizers, the leukotriene receptor antagonists, you're allowed to use muscarinic antagonists, which are Atrovent and Spiriva, and now other ones as well. So if you need a triple therapy for control, you're allowed to use that. Interestingly, theophylline is allowed, but that's a drug we don't use very much. If you're on a biologic, 2016, we only had omalizumab. The others are allowed now too, and antihistamines are also allowed. So there's now this prohibited list. So please don't just take this list as dogma. If you're a competitive athlete, go World Anti-Doping Agency, put the medication in that, search the prohibited list and see if it's on there. Please do not endanger your ability to compete based on taking something you shouldn't be. So the World Anti-Doping Agency is where to look that up. And again, as of fairly recently, you're allowed all these different beta agonists that we've got, and this sort of covers pretty well everyone that we use right now, except indacaterol, which is not included in this list. We talked about an infection. So when you have an infection, fever, congestion, that's not the time to push. And even in a few days after an illness, you need time to recover, because basically not only get one chance, but but you have the opportunity to actually recover and not get in trouble. Versus if you're inflamed for your illness, it can get you into issue. And this sort of shows that the likelihood, the linear predictor on the y-axis, is going to increase the more of having problems, the more symptoms that you have. So you're going to get more short of breath if you're sick. So again, you may be not doing yourself a big favor by pushing yourself through a viral infection trying exercise. I want to close down on a couple of other factors quickly. Sleep is affected in people with asthma for a variety of reasons, be it the asthma wakes you up at night itself, being it common conditions like obstructive sleep apnea, being it just the fatigue that can occur, being it the stimulation of the beta agonist. Another reason why not to overuse beta agonists, that can happen. So you can see that people with asthma tend to have restorative sleep not as well as people without asthma. You see 50 to 62%. So get your sleep, right? If you're waking up at night for your asthma, you're not in control. You need to sleep for muscle recovery as well as an athlete. So you need to get that stage 4 sleep and the REM sleep for the muscles to recover. I found this nice piece of information on the National Asthma Council, which is the Australia Asthma Council, on sleep and asthma. And Jeff, I'll challenge us that we should perhaps put something like this onto the Asthma Canada website as well. Cannabis, is that cannabis good for exercise? So I get asked questions like this. The answer is no. First of all, if you inhale anything into your lungs, it's bad, so don't do that. But even using cannabis as a gel, as a gummy or an oil, actually may cause some lack of coordination and decrease sporting performance. It can also cause your heart rate to go faster and your blood pressure to fall. All of this is not going to be good for exercise, so don't do it. There's a number of really good exercise resources on the Quad AI, which is the asthma and allergy information group in the United States. Quad AI library. So there's the tool for that. You can look that up. They got a bunch of nice resources to look there as well. So overall, I want to summarize and say, we talked about if decreasing physical activity in asthma has led to these symptoms, make the right diagnosis, get your asthma in control, because activity is going to lead to bad outcomes on the far right. And there's good reasons for this physiologically, immunologically, and metabolomics, which is a lovely conversation related to the inflammation and so on, that we can actually improve inflammation by good asthma control. And exercise will not improve the inflammation potentially itself, but will improve asthma management. So I'll summarize and say the regular exercise is beneficial to everybody. It's also beneficial to people with asthma, and asthma is not a reason to not exercise. Make sure your asthma is in control. Take your preventative medications. Do the things you can do. Exercise in the right conditions as you possibly can. And if you have to train through these other conditions, do the best you can for that. We talked about EIB versus EIA. EIB spirometry will be normal. other than during the exercise versus that's why we do challenge test. EIA, your asthma is not in control. You're getting symptoms. The exercise is a trigger. Get your asthma in control. And after all this, I'm hoping that a whole bunch of you is now going to go ahead and win some gold medals. So if you have any questions, here's the asthma and allergy helpline, and I'll pass it on to Jeff for some questions.
Excellent. Thank you so much, Alan. That was great, very informative. And we do have a number of questions that have come in both during the session live as well as some that were in advance. So we'll try to get through some of them. We won't be able to get through them all. But I'm going to give Alan a chance to catch his breath here. And Josh, I have a question that I think you might be able to respond to. So there were some questions around the routines that you have in terms of warm up and cool down from periods of exercise and running. So maybe you could share a couple of pointers for people in terms of what you find helpful.
Yeah, warming up and cooling down, extremely important for going out there and helping manage your asthma during cardiovascular exercise, especially now to kind of add to that, I mean, the more flexible that we are, the less our body needs to work, the better our lungs work because less exertion. So stretching, obviously very important during your warm up and your cool down as well. So for example, if you go out for a run, well, you don't want to just stop rapidly. Your heart rate gets extremely high, you come to a stop really quick. So take your time to cool down, do what you need, and again, stretch as well. If you go from running, go to walking then. Again, don't just stop, or try to switch it up a little bit as well.
Thank you. Alan, question. We've had a couple of questions come in from people who identify as being older adults or seniors. And they're asking, what is considered exercise? Somebody gives the example of walking at a brisk pace in the morning, using their inhaler first. Another person says, they're out of shape and very extremely out of poor shape. They say as a senior. What's realistic in terms, I mean, you talked obviously a lot about competitive athletes and so forth, but for somebody who's older and dealing with asthma, what do you recommend in terms of what might be helpful for them?
So I think exercise is going to be more than you do whatever you're doing normally. So we'll make it a very simple kind of thing there. And Josh, feel free to comment on here because obviously people are going to have different baselines when they're starting, and I can't run marathons, but Josh can. So that happens to be different. So if you're pushing yourself beyond your normal with the goal of trying to improve your health, and so on, then that's probably exercise. Does that mean that every time you walk briskly, you need to take a puffer first? No, I don't think so. I think you'll have to see whether that degree of exercise was enough to trigger these symptoms. It'll also potentially be different in different environments. Cold temperatures and things like that will be different. So I think what I'll call exercise doing something beyond your normal day in an attempt to benefit yourself, but that doesn't mean that that degree of exercise will trigger your symptoms. So that's important. So you'll find out how much is going to trigger your symptoms. Still, I probably do a little bit of warm up. That's really just good advice anyhow. But we don't necessarily want to take medications unless we have to. So learn what your threshold is at which you're going to need to take medications. Josh,
Okay, thank
what do you
you.
think?
Josh, do you have
Yeah,
any?
I don't have too much to add to that. I think what Dr. Kaplan said is kind of right on the money. Essentially, what you're doing now, a little bit more than that, really is considered exercising. Now, what I do when I go out is I really follow my zones, so my heart rate zones. If you have your zone 1, zone 2, zone 3, zone 4, zone 5, if you don't know what that is, please look it up. And I find that when I go outside of that zone 2, which for me would be a higher heart rate than say 145, which is beats per minute, that's when I start finding that my asthma becomes a little more worsened. So I try to aim to stay in between a specific zone so that I can manage to keep exercising just a little bit longer. So zone training is important. If you don't know what that is, I highly do recommend to do a little bit of research on it and find out where your zones sit.
Thank you, Josh.
The zone, sorry, Jeff, the zone, I just want to warn, the zone is age dependent and medication dependent a little bit. So obviously, people who are described themselves as seniors should not be aiming for heart rates 145, just as a bit of advice, especially if you have the concomitant conditions like cardiac conditions. So again, you want to push yourself, you want to get your heart rate up. If you're going to be go take this as far as Josh and competitively, then those zones are fantastic. But those casual exercise athletes, as we talked about, as you described, Jeff, just push yourself a little bit, see how it goes, and keep pushing yourself a little bit more, as we talked about.
Thank you. So we have a number of people who are, as I mentioned, older adults, but we also have parents that have joined us who have children that have been diagnosed with asthma. Is there anything that you would recommend in terms of activities that children should not be advised to participate in, or is it more sort of an individual trial and error thing in terms of how they respond to different types of sport and exercise?
I think first it should be something that they enjoy. Exercise should not be a burden. It should be something you love to do. And so whatever sport that's going to be. My key message is for the parents of asthmatic children is don't avoid exercise because they've got asthma. Okay? They should be able to exercise normally, should be able to keep up with their friends. And from the literature, from the work we've done over the years, we found that the number one thing that bothers children about asthma is not being able to keep up with their friends, but they may not be able to vocalize that. So let's encourage them to be out with friends. And if they're not able to keep up, then their asthma has to be managed better, or they need to be doing more exercise to get into better shape. So I think what they enjoy is first of all. After that, I'd mentioned that some of the longer distance stuff is going to be a little harder on them than shorter distance stuff and the short sprinting stuff for overall exercise-induced bronchospasm. But first of all, they should enjoy it. It can be competitive or not competitive. It doesn't have to be competitive, and they can still going to get health benefits from doing it. So it's a bit of a vague answer, Jeff. I apologize, but I think we shouldn't be pushing kids into an exercise they don't like, because it's unlikely they're going to keep up with that. They're going to be somewhat upset about that down the road. Josh, I don't know how you picked marathon running as your choice of exercise. But again, obviously he does it because he loves it, and that's probably the best answer.
Just before you comment, Josh, I know, having worked with you on a number of initiatives and heard you share your story a number of times, you talked about the fact that as a kid you were not able to play hockey and participate in certain activities that you wanted to. And a lot of that, I believe, came down to your asthma being poorly controlled.
A lot of it was, most of it was. I certainly didn't live in a good environment that would help my asthma. You know, I was infested by triggers, and really the educational piece wasn't there for me to rid myself of that environment, I suppose. Um, and I was told not to exercise, and my parents told me not to exercise as well, and certainly not the right step. But at the time, that's what they knew was right, so I should not exercise. And that led to me feeling very ostracized at school. And that's not a good place to be. Don't put your kids in that situation. I have two kids of my own. They're 2.5 years old. I have twins, and they're both on inhalers as well. And I'm going to let them do what they want to do and how they want to do it. And of course, making sure they're on the right stack of meds and making sure they're doing it safely, and as well creating an educational piece for their coach or the students around them or other people as well, because there does exist a stigma behind asthma inhaler use, unfortunately, and I think it's important to break that.
Good points. So we're right up against the clock. I just want to get one more question in. I'll throw this out, I think, to Dr. Kaplan first. Al and Josh, you can join in as well if you have any comments. There were a few questions that came in around supplements and the use of supplements and what might be helpful when considering exercise and living with asthma. Any comments on anything that could be recommended or avoided, conversely?
I did mention having a good diet and avoiding some of those processed foods and sugary foods and things like that. Trying to get ideal weight is going to be there. Supplements themselves, I'm not convinced there's a whole lot of value to that. I think if people are be competitive athletes, they need to have enough protein in their diet to be able to build muscle. If you want to take that in the form of a supplement, fine, but probably just a good healthy diet is going to be for there. And if you're eating a good healthy diet in North America, the reality is you don't need a whole lot of vitamins for the most part. You just don't need all that stuff. So sufficient protein in your diet is going to be important. Avoiding a lot of carbs, avoiding especially processed foods and ultra refined sugars and things like that. I don't know if you used anything, Josh, but that's
No, absolutely. What you said, Dr. Kaplan, and then I will as well kind of add, aside from diet, you mentioned recovery earlier as well, and protein. So taking protein, taking the time to recover is going to let your muscles heal, let them grow, and you're going to exert yourself a lot less when you go out and you exercise.
Great. Well, thank you
there's
both.
there's for a little while, Jeff, there was this thing about chocolate milk after exercise improving your recovery and so on. So I don't know if it works or not, but it tastes good. So go ahead, guys.
I like that. That's good advice. Thank you both again, Dr. Kaplan, Josh. We really appreciate you joining us. Thanks for your excellent presentations, the insightful Q&A. I wish we had more time for all of the questions that have come in, but we will be sharing this webinar. And if you have additional questions, I would encourage you to please reach out to us through our asthma and allergy helpline. We're always here whenever you need us. We also offer a number of different webinars that have been recorded over the years. So please check out the resources that we have at asthma.ca. And finally, if you found this information and the other information that we provide and support valuable, we are a registered charity, so I would be remiss if I didn't get in a plug here at the end to consider making a donation to support the work that we do. Any amount is truly appreciated. Thank you again to our presenters, and thank you all for joining us today. Have a great day.